I will be doing the attending physician reading this week. A 27-year-old Hispanic woman presented to the University Medical Center Emergency Department in Las Vegas, Nevada, with a sudden onset of shortness of breath and increased difficulty in moving her right arm. She reported that during the evening prior to her presentation, she was lying down when she began to experience shortness of breath with worsening right arm weakness. She also reported that for the past 2 months, her arm weakness was characterized as having limited strength and range of motion. She also complained of chest pains that were localized behind her sternum. The pain was characterized as a pressure sensation that was non-radiating. She did not have any aggravating or relieving factors. Pertinent positive findings included nausea, palpitations, and lightheadedness. Pertinent negative symptoms included no loss of consciousness, headache, vomiting, diarrhea, or vertigo. Our patient had been evaluated in the same emergency department 2 months prior to this presentation for right arm weakness and dysphagia. During her prior admission to the emergency department, she had received multiple MRI studies of her brain and cervical spine. A previous MRI of her brain had been unremarkable, but an MRI of her cervical spine had indicated some mild cervical canal narrowing, secondary to end plate changes, and chronic kyphotic changes. At the time of her previous admission, she was diagnosed with hemiplegic migraine headache. Her physical examination was remarkable in that her abdomen was firm to palpitation and her right upper extremity was rigid on passive and active ranges of motion. Her right fingers were clenched in a fist. When her fingers were passively extended, the digits spontaneously recoiled to the flexed and fist position. Neurologically, she exhibited some dysarthria, but her cranial nerves were intact. Meanwhile, EMG testing was performed in her right upper extremity muscles, including the dorsal interosseous, pronator teres, pectoral radialis, biceps, triceps, deltoid, and opponens pollicis. In all the muscles tested, frequent involuntary runs of motor units were identified. Through limb repositioning, her resting activity was studied, revealing absent fibrillations or positive waves. EMG testing of all of the muscles involved resulted in a normal motor unit morphology and normal recruitment. There was no evidence of myochemic or neuromyotonic discharges. Her EMG findings were consistent with SPS in the right clinical setting. Her prognosis is stiff person syndrome.